So it's a more technical case after all these ethical and more administrative and discussion. It's more technical. The fact about achalasia is that it's quite a rare disease, but still you will find like 27 patients per 100,000 people with a prevalence, and often it's diagnosed too late. There's esophageal cancer, and there's increased mortality due to aspiration often in the respiratory tract. So I will tell you the case of a 77-year-old male who came in August to us. He had initial symptoms of dysphagia already since 2004. There was a fluoroscopy actually in 2008, but no consequences were taken at that time. And in June 19, there was a suspicion for achalasia in the esophagogastrogrudoscopy, and he had a fluoroscopy done who showed a delayed clearance in the esophagus of contrast agent. So here you see the typical bird peak appearance and actually a typical achalasia type fluoroscopy. The next step were to have him a high-resolution manometry done in the esophagus that was clearly diagnostic for achalasia. All swallows had failed peristalsis. There was a panesophageal pressurization for 50 millimeters of mercury. And finally, the diagnosis was a type 2 achalasia. You see here that all swallows have failed peristalsis, and there was no relaxation in the lower esophageal sphincter. So in August, he had a regiflex balloon dilatation. According to the New England protocol, it was a 30 millimeter dilation, and it was 60 seconds, and we didn't go beyond 10 psi. So this was the typical view, as you may have it. First picture in a patient with achalasia. You see the foam forming. And then there was the dilation that occurred without any problem. We saw a tear. And when you looked more precisely on it, you saw that there was quite a wide rupture. So the endoscopist who was in charge did a fluoroscopy, and the fluoroscopy showed actually that there was an intramural extravasation of the contrast, and apparently there was still a clearance to the stomach, and there was a communication between the endoscopist and the radiologist. Is it a transmural eruption? Is it perforation? And the radiologist said, no, it's rather incomplete. And so, unfortunately, the patient was discharged home. Would you discharge this patient? No. Okay. So the patient went home and had soup. When he came back in the night with a big pain, there was something else than a white non-transmural perforation, but there was a true perforation in the mediastinum. And as you can see, it was it looked really, really bad. And this was the mediastinum. You see the parts of the soup. And they thought it might be a good thing to rinse it to get out these pieces, so they went back and rinsed the solids out of the mediastinum. Okay, so this was really a bad case. In the first step, as the surgeons usually want to do it, and we tried it earlier, you try to put a fully covered metal stent and then a probe, a 3 lumen probe to get enteral nutrition. And as you see here on the CT scan, this was before endoscopy and this was after endoscopy. You see on the right slide, you see here the stent, the self-expandable metal stent fully covered, and the pleural drain that was put in by the thoracic surgeons already. So the conclusion the same day at midnight was that there was a iatrogenic esophageal perforation following pneumatic dilatation. And it was a large and complete transmural esophageal perforation. And it was sealed with a fully covered stent. And there was enteral nutrition installed. 16 September, like 2 weeks later, a little bit more, we took the stent out and put an isosponge, and the transmural perforation was still there, but a little smaller. The patient was, meantime, was still on enteral nutrition, but it wouldn't heal completely, so maybe the initial stent choice was not the right one, but he was still doing more or less well. So we took out the covered stent. This is the stent. You see still the perforation there. And then we put you see the perforation that is covered with fibrin. And we put the isosponge intraluminally. You see here the perforation. We kept the sponge intraluminally to avoid that we would have a vacuum on the big vessels. So 27th of September was a good day for this patient. We could take out the sponge, and it was completely closed. And we performed the video fluoroscopy showing that there was a normal passage through an open esophageal junction, and the patient was discharged after that, and he's doing well. So there is certainly a discussion how to treat these perforations and what are the risks. There is in clinical gastroenterology is a paper accepted on the last systematic review. What are the patient-specific factors? It's the age, the manometric subtype, and presence of a sigmoid-shaped esophagus. Then the manometric subtype is really the most relevant subtype to see if a certain treatment of achalasia, either dilatation, POEM, or myotomy will work. And if you look now at the perforation rates in different series, you will see that, as in the New England Journal protocol, the 35 initial millimeter was abundant because they had like 30% of perforations at that time, with inflation time of 60 and 60 seconds, and inflation of only 8 psi, or here 10 psi, excuse me. And in the following study, when they followed the protocol of upsizing the dilatation diameter from 30 to 40, they had no perforations. So there are certainly technical reasons why perforation can occur, but on the other hand, we did at least to our estimate the right protocol, and we still had a major perforation. So probably there is an underreporting also with 30 millimeters. You can't be sure doing 30 millimeters that will be okay. We could have done POEM, but on the other hand, POEM is not as easy, and there are few centers, and in a achalasia type 2, in an older patient, dilatation seems to be accurate. So there are multiple risks and factors associated with achalasia treatment, and to make it short, still there is a a danger to perform dilatations at 30 millimeter, but it's the right way to start and to go up electively to 35 and 40. And management of even large perforations can be done successfully with usually stents and isosponge. Maybe we would have, next time we would put an isosponge first, but I hope next time will be only in 10 years and we will have another possibility to solve the problem. So thank you very much for your attention.
Okay, thank you very much. Any comments for this case? Yeah, Siwan?
I think the microphone's on.
Oh, yeah. Oh, sorry.
So a question and then a comment. Do you know if that patient made a complaint about the original endoscopist?
No, he didn't. No.
So the reason I say that is a third case I didn't have time to present was we had a similar case in our institution which resulted in a complaint. But I think an important point to bring out that I didn't have time to bring out is that the patient's complaint was not about the management, but the patient had to be transferred from one institution to another institution. And although the team the endoscopist and the team had caused the perforation were in touch with the family and with the GP and with the team, the surgical team where the patient went, there was no direct communication to the patient because he was in hospital for a protracted period being sorted out. And so I think that's something that sometimes gets forgotten in this, and talking directly to the patient, even if it is quite a long time after the event, even if they recover and make a good recovery, is so important because of the trauma associated with it. So they can be managed perfectly well, and patients will often understand a technical complication. But again, it's the communication about that is so important.
Yeah, I think absolutely. We have our own ward in gastroenterology, and we keep the patients after our complications, so they stay in our unit and they are visited always by the same gastroenterologists and endoscopists. I think that's really important, not to give them to the surgeons and to say they will solve the problem and we are out of the business. It's really you have to take care of them and talk to them. The only thing is when you say we made a mistake, then you have a problem. You have to say it happened and we are sorry. You shouldn't tell them that you have made a mistake, otherwise somebody of their family will then ask the lawyer to look at it. So that's even if they don't want that anybody does complain, but then they are forced more or less to do it.
Jan, you had a comment?
No, I was just going to say that there's a fairly large amount of literature that patients and families don't usually bring legal action because of a technical adverse event. They bring a lawsuit because they feel that they've not been communicated to, that we've not respected them, that we've not been empathetic to them, and that we don't, and we sort of blow them off in an American terminology. That's what causes people. They get mad at that. They're very forgiving of if there's a technical adverse event. It's how we act after that is really what causes them to sue.
I have one question with respect to the immediate management, to also all of the faculty. If you go in and see this thing, which you see submucosa, and do you push the diagnosis? Do you say, take a cap, I want to know whether this is open or not? Or do you go out and say, there could be a perforation, let's wait and see, maybe it heals? It's a serious question, because both could be advocated for.
So usually the more experienced you are, the more you want to see what happens. So usually we would put contrast agent directly during the endoscopy. That would be the normal procedure. In this case, it wasn't done. It was more like somebody who does more functional manometries and so on. And
so meaning that it should be done in the fluoroscopy room?
No, we do it immediately. We spray it on the perforation and look at it during the endoscopy when we So achalasia is always done with a X-ray inside the room. So usually you should look if there is a perforation, if you think there is. But maybe it was, I wasn't there in the room, so I can't tell you how noisy or how nervous the endoscopist was. So she sent we do usually a fluoroscopy after the procedure to make it sure. So, and then she believed that, and the endoscopist believed that there was no rupture, no real rupture, because the radiologist wasn't sure about the true rupture. So there were different findings that were not interpreted correctly. Excuse me, Hans.
Well, one reason for doing the gastrografin swallow after the dilatation is to find out if there is a perforation.
Yeah.
And then there was the strategy, at least in Munich, to do a myotomy right after this. Like to do it within the first 2 hours. If you have a perforation, then do the myotomy, close the perforation, and just add the talfundoplasty, so you have a safe closure. Would that be still a strategy?
Oh, I don't think in this case, because it's too high up, you know. I have assisted to many myotomies from the endoscopic way, and they can't get as high to close it. And if you have already a perforation in that height, you will have to mobilize everything. So I'm not sure that and it was too late in this case. Yeah. He had already an infection in his mediastinum.
Yeah, that's the second point. The perforation was actually above the ileus, right?
Yes.
And
yes, it was in the esophagus.
From the fluoro, it looked like the balloon was actually above the ileus too. So, do you do fluoros positioning of the balloon, or do you?
There was a
endoscopic positioning.
lipiodol injection at the EG junction, and I thought it was correct, but we would have to look at it together. But we do a lipiodol injection.
To Thomas's question, how aggressively should we interrogate such a defect acutely? One of the guiding principles I've seen in the literature is that if you recognize a perforation acutely during the procedure, the effective closure rate is extremely high, more than 90, and in ESD almost 100% now. So it's shifted my thinking to be very aggressive at ruling out a perforation when you have some suspicion, because you could clip it closed, you could suture it closed. But once you have that dirty contamination with the soup, you have very limited options for closure.
Yeah, exactly. Yeah.
And the other question also is, what type of surgery are we facing, you know, if we do it acutely? Is it really that type of surgery Hans is describing, so everything is fixed and fine? Or will it be a esophagectomy with pull-up because you can't close it?
For us, there's always a question if it's a covered perforation or not. But this was a free perforation, a pleural empyema. So the most important is to rinse the cavity and then probably try to put an esosponge in. But if you do surgery, then it's an infected area, so it's very difficult to
I'm speaking about sending the patient, as Hans said, immediately to surgery. So do we have a guarantee? No guarantee, but is the likelihood high that you fix the achalasia? Or will the outcome be that, the hole can't be closed, so we'll do a gastric pull-up?
Well, we would try to perform the myotomy and try to suture the perforation. You can open the mediastinum transhiatally from the abdomen. This is possible, and then you can suture it and put the big drains into the left pleural cavity to rinse it and to clean it up. So it would be possible to do this without esophagectomy. We would try it, yes.